at the picture. And that is why, in that case, I would be avoid of additional manipulation maybe.
And for you, it's not so important that it's too late infarct, myocardial infarction, more than one day.
That is why thrombus is so huge.
Yes,
of course, thrombobstruction is the first choice, maybe sometime with dilatation, pre-dilatation with not reference diameter.
Thank you.
Yeah, no, Dr. Kumsas will tell us how he would treat.
Good morning, and thank you very much for the invitation to this session in Paris. So, how I would treat this case. So, this is my conflict slide. So, brief clinical situation summary in cath lab. There is more than 24 hours after symptom onset. Patient clinical status is relatively stable, and coronary angiogram shows right coronary artery lumen with large refractory thrombus. So, from evidence, of course, we know that there is no doubt that we should try to do revascularization in first 12 hours, but however, how already Professor Erglis mentioned, in real life situations could be different. But also, the current guidelines of revascularizations says that reperfusion therapy with primary PCI should be considered in patient presenting late, 12 to 48 hours after symptom onset, and it's 2A. From pharmacological treatment, what I would like to point out that, of course, it's quite clear that we should give DAP therapy preferably at first medical contact, which was unfortunately not done in this case. Regarding GP blockers, of course, if there is thrombus, complications and neuroflow, there is 2A class of indication, and upstream GP blockers for cases with high risk cases which are transferred for primary PCI. That's coming from evidence. As already previous speaker pointed that unfortunately, and it's actually, I would say, even was a bit unexpected and disappointing for the interventional community, current data don't support routine thrombus aspiration in primary PCI patients. Also here we can see meta-analysis from 18 studies showing no benefit of routine thrombus aspiration, but however I would like to stress the word routine thrombus aspiration and maybe in this slide. Also, this slide was showed in previous presentation, also for late presenters. It's small study, 152 patients, thrombus aspiration didn't show any benefit. What else we can do in such a situation where we are faced with such a really big thrombus mass? And there are some data we can, it's coming from Atlas study that we can add to dual antiplatelet treatment anticoagulants, and it was in this study it was rivaroxaban 2.5 milligrams twice per day, showing really significantly better results in endpoints at 2 years. So, keeping that all in mind, my strategy in this case, I would use GP to B3A blockers in this case. I would use thrombus aspiration in this case, preferably 7 French, and maybe we cannot expect in this case that we will restore with thrombus aspiration all blood flow, but at least we can try to get TIMI 1, TIMI 2 flow, and as we know that blood flow is one of the best thrombolytics. So, and definitely I would not put a stent in this thrombus mass because I think we would not get good result with that, at least from my experience in such case. I would schedule this patient for control angiogram after 1 month and add to dual antiplatelet therapy rivaroxaban 2.5 milligrams twice per day. And I think we really need big time in this case. And to finalize my presentation, this is a citation from great Russian general Mikhail Kutuzov after the historical Borodin battle: time and patient, patient and time. An apple should not be plucked while it's green, patient and time. Thank you.
Questions? Short questions, please. I have some questions. You said about the GP2, GP2, B3 before, at first day, or simultaneously?
Well, it's before it's could be discussed, but I definitely would give a time of procedure when I see such big thrombus and maybe continue at least for 24 or 48 hours this infusion. And of course, one remark, when we add this anticoagulant to therapy, of course we have to look on bleeding risk for patients. Of course, we have to look in anamnesis if there is some previous stroke or some hemorrhagic complication. That's, I think, important for us. We add such, start such therapy.
Is Kutuzov the only one eye?
Yeah.
Thanks, but you have two. Yeah.
Very large. Very large.
That's why we should look on with both sides to this. Okay, but no, this is a really, I like very much that both actually speakers not only to concentrate on what they would do, but also based on theory and I mean literature. But of course, on the other hand, this is also very practical meeting, and that's it's again, because you also have so many cases. What you would do, even this is very nice what you say, but how you start if you see it's a late thrombus and then so big one. Well, and for example, if some younger colleague came to you as chief of lab and says, you know, I put a 6 French and what I should do and what's your advice and what you would say?
Maybe as I said, if we are thinking about suction, it probably is better to use 7 French because it's mechanical thing, it's a bigger hole, and I would wire the artery and then try to do thrombosuction. Really take maybe some 2.5 balloons, try to restore some blood. I think the aim could be just to get TIMI 1 to TIMI 2 flow, because in such cases it's very rarely we can expect that we will get TIMI 3 flow and nice place for stenting, I think, and then that's but of course it would be different, but yeah.
Maybe we know to ask that to show what she did.
I would like one comment. Don't forget that a coronary angiogram was made on next day, and we have 1 day before coronary angiography for treatment this patient. It is very important. And all about the thrombolysis, about the drug treatment, we can perform it the day before coronary angiography. It is very important, and we forget this.
And okay. And also, actually, this is I don't think so that it is. Maybe next time we also will ask in cases like this for left side, because it's very important about collateral things, and that's you are like very good.
Collaterals.
No collaterals.
This is actually because as you as a retrograde operator for CTOs. you always are checking and looking on collaterals, and in this case it is very, very, I think, important point. What's happening with collaterals, what's happening with distal part, and this is also change our strategy. But there is no collaterals.
No collaterals at all.
Instinct.
But a very large scar, yeah?
Yes,
In
it
this
was the same zone, previous QMN
Yeah,
in
yeah.
inferior wall.
It is also very important.
So how did I treat the case? I will remind you, this was the last picture of right coronary artery with not satisfied flow distally. So, and actually we stopped at this point. Patient was transferred back to in cardiology department. And we decided to put patient on aggressive medical treatment. As you can see, 3 medications was targeted to thrombus dissolving. And actually you also can see that quite a lot of medications for myocardial salvage. We took patient back in 1 month and performed repeated angiography, and we was very happy that thrombus is totally disappeared. On ECG you can see the same scar in inferior wall, and after coronary angiography we recommended just 2 medications for 12 months, extended release metoprolol, ivabradine, ramipril, varispiron, atorvastatin, and pantoprazole. Thank you.
Thank you. Thank you. Any questions?
Yes, please, questions and discuss. We opened the discussion. Actually, I guess all speakers could come maybe and to discuss theirs. Yes, please.
As I mentioned, there was a stent in the right coronary, yes?
Yeah.
Yes.
And what kind of stent it is?
What kind of
It is
stent?
biometal?
Yeah,
Bare metal, yes.
Biometal stent.
Yes.
And as my opinion, if we have instant thrombosis, I think the first choice it should be thrombosuction. Because of course the guidelines says that routinely you avoid to use thrombospiration, but if we have instant thrombosis, I think usually we have organized thrombus, and we can try to aspirate it as a first choice. This is my opinion.
Yeah, I agree, but this is always the answer from operators. You know, it's all thrombus. This is what we get, and even they don't like to try. This is what we every day. Just a second, yes, please. Yeah.
I would ask you about medicine in acute phase of myocardial infarction. What is your attitude to predictal? I saw you administer predictal after discharge.
Actually, in this case, we just wanted to give a maximum of all medications to prevent recurrent ischemia, to give more help to myocardium. Maybe that was the reason.
I guess it's a long discussion about meldonium and then cimetazidine. I'm not sure that we should not go inside in this, but actually this is a nice question, because I guess you know very well about that. Yes, please.
I wanted to ask about anticoagulation, Xarelto 2.5 feet a day. We have only 15 and 20 milligrams, what doses is it? Maybe you mean Apixaban.
No. If you look on Atlas study, in Atlas study there is 2.5 for acute coronary syndrome.
Yes, but we have dosage only 15 and 20.
There is also pills in pen.
And you make it 4.
Yeah.
But it's very low dosage.
Yeah, but it's proved in Atlas study for acute coronary syndrome.
Actually, there was also a group with 5 milligrams twice a day.
But you can come into the center and discuss too, and yes, please.
Thank you for your occasion.
Yeah, but you guys, you can, no, stay there and you all three can come and or sit or
Do you
whatever.
have maybe some experience with aspiration through the catheter maybe, or through the guide extender catheter? Because a lot of actually beyond the guidelines, a lot of
And
doctors
use the mic.
who aspirated through the 5 French guide catheter, for example.
Yes, we
And
do.
there is a mic too, and then everyone can see.
We do that way of the thrombus suction, but only in very large vessels, not in coronary, maybe in leg arteries. Yeah, it's allowed, but in coronaries we only try to use larger thrombus suction catheters. In leg arteries, yes, we do aspiration with diagnostics catheters. Yes, in leg arteries, not in coronaries.
But actually, they have a question. What was the reason, particularly in this patient, not to use thrombosuction?
Yeah, it depends on operator. It's not my patient. I just wanted to show you what to do with very large and organized thrombus. So maybe I also would take thrombus suction catheter, aspiration catheter. So, but it depends on operator. I agree absolutely.
What I'd like very much is what we've seen, and it's not the first case, and maybe Ingles to add, because I really seen how works this three medication combination. Actually, if you look on some studies from Denmark, and also Sergey shown us studies, that it's really interesting about this, thrombus resolvation actually in those patients. But what I want to say and ask for a very practical point, you all three says about 2.5 balloon, and what do you think or what do you recommend the length of balloon?
I would use long balloons, 30 millimeters in such days, definitely. And just one more remark about thrombus suction in such days. I would be very careful with guiding. You have to afterwards suck back quite a lot of blood from guiding, because in such situations there are some thrombus could be in guiding, and we know, and then you can suddenly get even stroke. You should be careful with that one in such cases.
And this is about thrombus fragmentation. It's really important. Yeah. So maybe you have some comments, or but maybe use the mic because otherwise it's difficult. Yeah, we have 1 minute. Yeah. 1 minute.
I would like to remind the colleagues about some very interesting devices, some porous balloon, which can be filled with 2B3A angio blockers and small with a low pressure, and this balloon you should hold in the coronary artery with low pressure, and medication go through the pores into the thrombus. And we have a small experience with a balloon like stream, maybe it's called like stream balloon. It's quite promising in cases with huge thrombus when you work with the balloon with a lot of pores in the walls. And another point is the intracoronary infusion with 2B3A inhibitors. But how long we should do it is a crucial point. And another subject is for what we have to delay this patient for 1 month. I think for resolution of thrombus, 1 week is absolutely enough, and make it in the same session for decision what we have to do with patient.
Yeah, but it is not so important. You say that after 1 week thrombus is resoluted, yeah? And when you will prefer stenting or angioplasty after 1 week or 1 month, it is not so important.
They have to prevent recurrent ischemia, recurrent heart attack, and so on.
I would be careful about this statement, but this is under discussion. At least we are not keeping patient for 1 week in hospital usually.
So.
Yeah, Professor Iosseliani will give us. Thank you very much for great questions and great comments and discussion.
First, I would like to say that I have not any conflict of interest. And I would like to say that a very interesting case was presented, very interesting, with an unusual, unusual strategy of treatment, and it is very interesting. It is impossible to make everything like in guidelines. We have, and we possibility, we must make improvisation during our work. It is very important, especially for the specialists with a big history of working in interventional cardiology. It's my opinion. And about this case, first, as we can see, the patient was admitted to the hospital in 6 hours after the onset of angina attack, a little later, yeah? And a very long time was for the call ambulance, 4 hours approximately. This is very typical for Moscow also, not only in Latvia. At admission, he had no more pain. On ECG, there were no signs, no typical signs of acute myocardial infarction. However, cardiac enzymes were elevated. Also, there was the data suggestive of an earlier myocardial infarction suffered in 2000, as well as that in 2007 the RCA was stented. Sorry. Probably the physicians had this reason in mind as the patient was transferred from emergency cardiology to the ICU. Also, it was decided to perform coronary angiography on the next day. Prescribed therapy included clopidogrel, aspirin, enoxaparin, and I think eptifibatide also.